Good evening, one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the 34th episode of Optometry series. I would like to thank each and every one of you for your continuous support towards Optometry series. And I'm very happy to welcome my team members, Ms. Anshi ma'am and Ms. Meenakshi. Hi, both of you. Thank you so much for joining today. Yes, Anshi ma'am, it's time for you as to reveal the today's topic and the valuable moderator for the day.
Yes, so thank you, Gomati, for the introduction. Today's topic is on nystagmus. Why nystagmus for this month? Generally, June 20th is celebrated as World Nystagmus Day. And we wanted everyone to, get back to books and know more about nystagmus. So we have one of the best people, our moderators today, Ms. Deepa, joining us from Srihar. She works as a faculty at Sri Ramachandra Research Center and Hospital. So she's also done her fellowship with NORA, which is neuro-optometric rehabilitation. So she would be the right person to tell us and give her inputs about how we can manage and take care of nystagmus. So over to the introduction to Deepa ma'am. So we'll start the series.
Yes. Thank you so much, Anshi ma'am. Yes, Kavya, you can start with the MC work.
Good evening, one and all. I'm Ms. Kavya, studying third year Bachelor's in Optometry at Dr. Agarwal Institute of Optometry. It is a great pleasure to welcome you all today. We are honored to have with us an exceptional guest whose contribution to the field of optometry are both profound and inspiring. Please join me in welcoming our distinguished guest, an assistant professor at Sri Ramachandra Institute of Higher Education and Research, Ms. Deepa ma'am. Ma'am currently pursuing a PhD part-time at same institution with an inspiring of 20 years of experience in optometry. Our guest has been intensive educational background, having earned both BS Optometry and an MPhil Optometry from the Allied School of Optometry. Furthermore, ma'am have completed a fellowship in pediatric optometry and orthoptics from RBS Shankarnetralaya. Our guest's dedication to advancing optometric science is evident through their numerous presentation and publication. Recently, ma'am presented an oral presentation at Neuro-Optometric Rehabilitation Association Conference in Portland in 2023. Ma'am also presented a scientific paper at American Academy of Optometry Conference in San Diego in 2022. Ma'am is also a recipient of numerous prestigious awards, including NORA Travel Grant, the Peter Ackland Scholarship from the Peak Vision Foundation, the INSE Research Excellence Award from the Institute of Scholars, and the Gate Young Faculty Grant at Sri Ramachandra University. Her excellence in research is further highlighted by guiding postgraduate optometry research study and receiving the best poster paper in binocular vision at International IVI Conference. Deepa ma'am's research interest spins around the binocular vision, neuro-optometry rehabilitation, vision therapy, and behavioral optometry. Ma'am continues to make a significant trip in a field shaping the future of optometric care and education. Thank you for joining us, ma'am, in your busy schedule. Your experience and dedication serve as inspiration all of us, ma'am. Thank you, ma'am. The presentation for today is Ms. Divya Bharathi, studying second year Masters in Optometry at Dr. Agarwal Institute of Optometry. Ms. Divya Bharathi, please start your presentation.
Today's topic is about nystagmus.
Yes, Divya, you can proceed.
Yes, ma'am. So nystagmus is defined as involuntary rhythmic oscillation movement of eye, which will be followed with slow eye movements and fast eye movements. Either it can have both to and fro as slow and slow, or slow and fast movements. Another slow movement in the opposite direction. So if it's going to be slow and fast movement, we will term it as jerk nystagmus. And if it is going to be slow and slow, we call it as pendular nystagmus. And it can be also broadly classified as pendular or jerk nystagmus, or based on the movement, also we can classify as rapid or slow movements, fine or coarse movements, and sometimes it can also be a hidden one, blatant or manifest deviation. So it can be broadly classified based on the history, whether it is an early onset or a late onset, and with the presence of oscillopsia or oscillation, hallucination, and abnormal movement away from the fixation. It can be slow or fast movement, and corrective movement can also be slow or fast movement, and direction based on the plane of the movement. It can be either horizontal movement, which will be having right or left movements, or vertical up and down, or rotatory, which is anti-clockwise or counterclockwise. And it can also have conjugate movements between both eyes or disconjugate movements between both the eyes. And it will also depend on the visual acuity, and also associative involuntary movements such as palate and head and neck movements will also be the associative factor, and it can also be classified based on those terms. And it give this shows you what is the difference between the pendular nystagmus and jerk nystagmus. Pendular nystagmus is going to have a sinusoidal oscillation movement, which will have slow phase direction in both the direction, which even in the to and fro movement, it is going to be the slow movements. And most of the pendular movement is going to be associated with horizontal and vertical deviation. And it is not characterized by right and left movement, downbeating, as there is no fast pace. And jerk movements, so you will see an alternative phase between to and fro movements, which is rapid corrective saccadic movements in opposite direction. And direction of jerk nystagmus, which will be equal to the direction of the fast phase also. And it will have a combination of right or left beating nystagmus, sometimes upbeat and downbeat nystagmus is also possible. And types of nystagmus, again, it can be classified based on the direction, which direction the movement is being presented, again based on the plane, whether it is having horizontal movements where it is moving right and left, and vertical, which is up and down, and rotatory, clockwise or anti-clockwise. And based on the intensity also, we can classify it as first degree, second degree, and third degree. Where in first degree, you will see the nystagmus only in the gaze position. Whatever the site is affected, only when the eye is moving towards the particular site, the nystagmus will be present. We call it as weakest form. And in secondary nystagmus, eye will have its nystagmus even if the eye is on the midline, which is your primary position. And tertiary nystagmus, which will be present in all the three gazes and positions. And what is the mechanism of nystagmus? So the main ocular movement is being presented to maintain the correct foveal centration, which is of the object of interest. If there is no visual fixation, if the central fixation is not there or foveal centration is not present, nystagmus will come into play. And if there is going to be any neural integrator or supranuclear pathway dysfunction, then again nystagmus is also going to be present. And if there is going to be imbalance between vestibular and ocular balance, then nystagmus will be presented. And this is going to be the broad classification of nystagmus, which will have physiological factors, pharmacological nystagmus, acquired, and infantile nystagmus. We will see everyone in detail. So the causes. So the causes of nystagmus can be because of dysfunction of vestibular anterogen and vestibular nerve, or the brainstem or the midline, which will also affect cerebellum, cerebral centers of ocular pursuits. Why in normal patient nystagmus is not present? In normal patient, there will be an equal normal maintained vestibular system will be presented, and symmetry will be presented in the primary position. If there is going to be any imbalance between the vestibular and ocular balance, then there will be the deviation towards the less active side. In patients who are alert, the frontal eye field will generate saccades to bring back the eye back to its primary position, which will create a corrective fast phase portion of nystagmus, which is associated with vestibular nystagmus. And in optic kinetic nystagmus. This is kind of a physiological nystagmus where it will be induced by presenting a gaze of object when the patient is looking at the optokinetic drum. Based on the strips of spinning, the eye will have its series of movements, and eye will also follow a fixed strip momentarily, and then jerk movement will be present. And similar condition will occur when eye is looking at outside when we are traveling. And endpoint nystagmus. This is again a type of physiological nystagmus when eye is moved towards the extreme gazes, which is more than 45 degrees, then you will have a fine nystagmus. So here in the video, if you notice, when the eye is moved to the extreme gaze, lateral gaze, there is a fine jerk nystagmus is presented. And a caloric test will also induce physiological nystagmus, where if you're gonna pour a cold water in your right eye, the eye will move towards the opposite direction, which is towards left side. Left nystagmus will be presented. If I'm gonna pour a warm water in the right eye, the direction of nystagmus is towards the right ear itself. So this is gonna have a physiological vestibular nystagmus is going to be present. And infantile idiopathic nystagmus. Infantile idiopathic nystagmus is going to be seen in the first few months of life, which is not usually noted at the birth, and it will have a characteristic features which is being denoted here as a mnemonic congenital, where when the eye is converging, the nystagmus will be dampened, and with convergence, the near visual acuity will also be improved, and oscillopsia will be absent. Why oscillopsia is absent? In hallucination condition, the mind should be aware about the condition. In infantile condition, that is not possible. So oscillopsia is absent in infantile conditions, and null zone will be presented, and the equal gaze position and uniocular movement will be presented in congenital cases, and inversion of optokinetic nystagmus. Normally, if the patient is going to see the optokinetic nystagmus, there is going to be a fast jerk movement which will refix it. But in this cases, in infantile idiopathic nystagmus, the patient will follow the optokinetic nystagmus, and further far away, they will move forward. And there will be a head turning to achieve the null point, and it will abolishes in sleep, and later nystagmus can also be presented. Sensory nystagmus. If there is going to be any sensory deprivation because of any opacification, then the sensory nystagmus can be presented, and it is usually presented between 3 to 4 months, and it is also been told in the mnemonic form, which contains 5 A's, which is aphasia, Leber congenital amaurosis, aniridia, and achromatopsia, and ocular albinism. Latent nystagmus. Latent nystagmus or fusional maldevelopment nystagmus, which is going to be a benign condition and early onset conjugate horizontal jerk nystagmus that only manifests after occlusion of one eye. And if you're going to find a visual acuity for this patient, in spite of completely occlusion, we can also put a plus filter before the eye. With that, it will have a good visual acuity improvement. Spasm nutans. Spasm nutans is going to present with the triad, which will have nystagmus and nodding and with the head tilt. If you're going to see this video, here the kid is looking at a toy with the head tilt and also head nodding. And this will always present in the first year of life, and it will spontaneously disappear within the age of 3 to 4 years. And this nystagmus usually will consist of small amplitude and higher frequency oscillation will be presented. Usually it will be bilateral, and if it is going to be a monocular condition, it will have an asymmetric variation between the gazes. And usually a benign tumor. Neuroimaging is recommended because a gliomas, which a lesion which is present in the brainstem or midbrain, can mimic like spasm nutans. Infantile monocular pendular nystagmus, where it is present in the infantile age group, which will be presented in one eye with the pendular nystagmus. Sometimes it can be a binocular vision loss too, but where in condition of binocular vision loss, the nystagmus will be greater in the poor eye. Gaze-evoked nystagmus. Gaze-evoked nystagmus is similar to whenever the patient is going to look at the particular gaze, that is more than 45 degree, the jerk nystagmus is going to be present. Again, gaze-evoked nystagmus is going to be usually conjugate movements and asymmetric will be present. And this can be due to the CNS deprivation or any structural pathological deficit. Convergence retractions nystagmus. This is not a true nystagmus. Whenever the convergence is present, along with the retraction, the nystagmus is going to be present. It can be more evidently seen when the patient is going to look up. And it is because of the midbrain lesion. And midbrain lesion is going to be because of the pretectal lesion. The preceptal region is going to be called as convergence center also. That is why the patient is having a convergence retraction nystagmus, since it is affecting the preceptal regions. Periodic alternative nystagmus, where the patient will have 30 or 60 or 120 seconds of nystagmus, and then it will not have any nystagmus. After few time, if you're going to notice, it will have an alternative direction of nystagmus. This way, periodic alternative nystagmus will be presented. And based on the vestibular nystagmus, because vestibular ocular nystagmus is also one of the greatest function which will have nystagmus. It can also be due to your peripheral function as well the central. So the peripheral will be mostly associated with vertigo problem, and the central will be mostly associated with inner ear or midbrain regions. And it, usually in peripheral, you can see mixed types of nystagmus. In central, you will only see a torsional nystagmus. And the duration of symptoms is going to be in peripheral, it is going to be recurrent and self-limiting. And in central, it is going to be a chronic one. And hearing loss, all of that will be present in peripheral nystagmus, peripheral vestibular nystagmus, and it is very uncommon in the central nystagmus. And if you're going to do a HAP-like procedure, where you will ask the patient to lie down on the bed with the one ears closed, they will have a fixation duration with the time duration of 2 to 20 seconds before the onset of nystagmus, if it is going to be a peripheral form. If it is going to be a central form, immediate onset of nystagmus will be presented after HAP-like procedure. And the common cause is going to be for the peripheral nystagmus is Labranus and Meniere disease. This is going to be the primary causes which will lead to peripheral nystagmus. And if there is going to be any demyelination, mostly a multiple sclerosis causes, that will lead to central vestibular nystagmus problems. And central vestibular nystagmus is again classified into many types. Bruns-Cushing syndrome, where in Bruns-Cushing nystagmus, you will see different amplitude of direction in one single eye. If the patient is going to look at the right side, it will have higher frequency. In the same eye, if the patient is going to look at the nasal side, it will have lower amplitude. And downbeat nystagmus, where in downbeat nystagmus, the movement is going to be slow and the corrector will have a fast jerk movements. And again, in most of the central vestibular nystagmus, the movement of the nystagmus is going to be the torsional one. Ideal torsional nystagmus will be presented. And if the torsional nystagmus is going to be present, mostly it is going to affect the brainstem or the mid region of the brain. And seesaw nystagmus. Seesaw nystagmus will have a opposite direction of movements in both the eyes. So if one eye is going to move up, it will intort, and the eye which is moving down, that will extort. So this way, the seesaw nystagmus is going to be present. Periodic alternative nystagmus, it will have frequency of 30 to 60 seconds where nystagmus will be presented. After some time, again, the nystagmus will be presented in the different direction. Convergence retraction nystagmus, when the eye is tending to converge and there will be a retraction, and in that cases, nystagmus is going to be presented. Pendula, you will have a to and fro movements. Dissociated nystagmus, in both eyes, you will have a dissociation of nystagmus. And these are going to be the etiology and lesions which will lead to a specific nystagmus, which is broadly classified under central vestibular nystagmus. And so if you're going to see this image, you will see an upbeat nystagmus where you have a slow phase and along with the corrective phase of fast recovery. And this is going to be a downbeat nystagmus where you see a slow downbeat and with a fast recovery. And this is going to be the seesaw movement. If you're going to notice the both eyes is having a different direction and a rotational movement is also being seen here. So here the pendulum movement is being observed. And this is the Brown syndrome, where in the nasal side, the patient is having more frequency but less amplitude. Here, the patient in the lateral case, just a minute. So if the patient is going to look at the lateral side, there the patient is having more frequency but lesser amplitude. So in Brown syndrome, in the same eye, it is going to have different amplitude of deviation. So nystagmus can also be associated with strabismus. And if it is going to be associated with strabismus, the latent and manifest is going to be big. The manifest nystagmus, it will always have a good visual acuity, binocular visual acuity. And lastly, it will be associated with esotropia, and normal, it will be presenting normal even with the cover test. But in manifest or latent nystagmus, it will increase in abduction, and it will also increase when you cover one eye. And fast phase always towards the fixing eye. And it will also be associated with esotropia, and binocular visual acuity will be better than uniocular visual acuity. Next one is nystagmus blockade syndrome, where it is the inverse relationship with esotropia, where the patient will have preferably will have an abduction and a face turn in the direction of fixing eye. So with the abduction and the direction, abnormal head position, the nystagmus is dampened. And these are the treatments available, the drug treatments, which will include gabardines, anticholinergic, and memetic. And optical device, we can give optical device, which will not fix the nystagmus problem, but it will improve the visual acuity. And surgical procedures can also be generally used to stabilize the nystagmus, which will be involving bilateral weakening procedures and Kestenberg procedures. Retrobulbar botulinum toxin can also be given, which will dampen the ipsilateral nystagmus associated with ptosis, diplopia, and vertigo symptoms. These are my references. Thank you.
Thank you, Divya Bharathi. It was a very great presentation. Ma'am, I would request you to add your points now, ma'am.
It was a very elaborative session of the nystagmus as such. So let's talk very practically about nystagmus. This is going to be more neurologically involved as such. So when we see, it is a sensory inhibition also that is happening. Okay, these are the inhibitory processes which are coming from the brain function also. So these are rhythmic oscillatory movements that are being associated whether through a brain lesion or it is ocular related. So first of all, we have to see how you are going to differentiate that. Is it going to be a systemic disease related type of neurological nystagmus, or it is going to be a manifest nystagmus or a simple seesaw nystagmus, or it's going to be a congenital nystagmus that is being involved as such. So if that is so, then we are going to treat ophthalmically and then go upon with it, right? So many of the time management, the last option will be the surgically innovation, because it's related to the brain system also. So you have to see whether you can get a neuronal feedback mechanism as such if possible. Otherwise, we have to see how optically are we going to treat them or manage them as such, right? So many times, if it is going to be associated with strabismus and all, we need to see what kind of a strabismus is it. Is it going to be a manifest type of a strabismus, or it is subtly related to the strabismus binocular vision anomalies as such that is being involved. Though it is going to be very difficult in case of nystagmus to go upon the whole orthoptic evaluation, but then it is mandatory that you look upon the various visual efficiency skills that are being there, such as the accommodation, the vergence, as well as the eye movement that are being there. Okay, this is the nystagmus is the last oculomotor dysfunction which is vaguely classified under the oculomotor dysfunction as such. So in such cases, we have to look into whether are they able to comprehend well the books and all, and what kind of a complaint are they actually associated with it, right? So if in case you see the treatment which is optically present, either you can go with high plus glasses or contact lenses, a high plus and a high minus contact lenses. This is because the proprioceptive innervation is going to be there along with the, when you put the contact lens in the eye, and the trigeminal nerve is going to actually innervate over there and then get a neuronal feedback, and it will settle down the nystagmus as such. Second thing, if the convergence is really good, then if the nystagmus is going to dampen down, then we can think about giving a base out prisms as such for these patients to dampen the nystagmus, as so on, to have a better living as such. Okay, so even the yoke prism nowadays are actually being tried if in case the patient is going to have a head turn or a head tilt. So which side of the face turn or a head turn that is being present, towards that the yoke prisms are being given. For example, it is a right face turn, the base right yoke prisms are given so that it dampens down the nystagmus to a certain extent, and the head posture is being nullified. Okay, so abnormal head posture, if in case it's being present, so we are going to treat them as such. So basically, these are the various types of options as such that is being involved, which can be done for these nystagmus patients. As she said, the latent nystagmus, yes, it can be seen very well whenever you suddenly go for a retinoscopy finding over there, and you see it's just oscillatory over there. So you fog the other eye with high plus lenses, and then you go upon with the refraction so that you get a better value for these patients, in case if a simple glass prescription is going to really work them a lot. So we have to see how are you going to manage these things. Okay, so these are the few things which you have to keep in mind about nystagmus as such. Coming into the vision therapy as such, nystagmus and the vision therapy, how far it is being done, we have to look out. Depends on the response of the patients as such. As I told, it is the last classification under the oculomotor dysfunction. You have to look for the saccadic and the pursuit movements that is being present for the patient. You can, through Ensuco oculomotor test, you can actually, grade the patient, how much is the pursuit and the saccade, or the development eye movement test, if it is available, then you can actually go with the quantification of it, and then go with various saccadic and the pursuit exercises that can be involved for these patients, starting with the Michigan tracking test. Okay, so these are the things which you can actually think about as such for an nystagmus, and depends on what at what age the patient actually presents with. All those things you have to keep in mind. Now, coming to the systemic diseases, the systemic diseases can be of various conditions, a brain lesion or any neurological disorders such as multiple sclerosis, Alzheimer's disease, Parkinson's syndrome. All these things are involved, which can be associated with the nystagmus. There can be a post-stroke condition that can be involved. Even sometimes there is a post-trauma that can actually will be involved. So if in case it's going to be a post-trauma, you have to look into various types of symptoms that are being there. Is it because of the post-trauma vision syndrome that is being associated? Is there a light sensitivity problem, or it is going to be tearing of eyes, or they are not able to read the text continuously? So based on that, we have to go upon the various vision therapy as well as the kind of vision therapy exercises which you can give in. Sometimes if the patient is going to a small amount of myopic glasses also can help out these patients to keep the eye straight. For example, it is an exophoria that is being present, and the nystagmus is also associated with that. A small amount of myopia can be given for the strabismus to come straight, and later, once the fixation is there, then we can go upon for the other therapies with the nystagmus that is being associated. Okay, so there are various other treatments also, like therapies, binasal occlusion and bitemporal occlusion, which is being, if necessary, that can be given, but it's not compulsory as such. A small amount of base out prisms can be given. You can give it as therapeutically, or you can give it in the ground in prisms as such, or you can go for a yoke prisms at office therapies also. Okay.
Thank you so much, ma'am. I guess the treatment part of nystagmus is very clearly explained right now. From the clinical perspective, for the understanding of student, how will you actually start with the evaluation of nystagmus, ma'am?
Yeah, first depends on the history. Okay, so the moment you see the patient, the history is the first thing, right? So what are all the histories which we can alleviate from the patient? We have to see, is it since birth it is being present, or it has happened very recently? Sudden movements are there. You have to look for those conditions, what it is all about. Is there any CT, MRI that is being done? If in case, that can help out. Is there any brain lesion that is being associated as such? Was there any glassware or any vision therapy exercises earlier that is being given, or any treatment? For example, she had mentioned about botulinum toxin injections that can be given for nystagmus as such. So all these things need to be noted to a certain extent when you go for evaluation, and document that. First and foremost thing are the abnormal head posture that is being present or not. Like as we ask for the binocular diplopia, the various questions you need to you need to ask about the head posture if that is being present, any old photographs that are being present, look for the nystagmoid movement as well as to the head postures that are being present or not. Okay, sometimes the head postures can be alternating also. So you have to see, is this head posture, is it because of the nystagmus, or it's because of a simple uncorrected refractive error like astigmatism also can actually, add on the nystagmus that can be there. So you have to give the proper optical correction for the patient before that, and then go upon with that. Okay, after that, you assess the visual acuity. So visual acuity, majority of the time, as go for an occlusion for a patient, the nystagmus actually aggravates. Okay, it doesn't reduce down. So you whether mandatory, it's like we have to mention about the uniocular visual acuity over there. But for nystagmus patients, we have to assess binocular visual acuity also, and document what kind of a head posture or a head tilt that is being present, with which they are able to read better. Most of the time, these latent nystagmus will have a better visual acuity binocularly, and then you have to go upon that. So after that, the subjective refraction, before you go with that, you have to see the objectively how much is the refractive error. So with the retinoscopy, when you're trying for an objective refraction, you have to fog the other eye with a high plus lenses so that the nystagmoid movement is reducing down, and then go upon with the objective refraction. On that, subjective refraction can be done monocularly and binocularly. Go for the binocular balancing if it is necessary, and look for the duochrome test for the endpoint of the subjective refraction, and then finalize what kind of refractive error, if it is being present, you're supposed to give. And after that, it is not only enough, all these things, you have to go for an extraocular muscle evaluation. Is there any cranial nerve palsy that is being associated with it? Or is there any extraocular movement, motility reduced down? Look for that. Look for the pupils also. Is it associated with any other Horner syndrome or RAPD that is being involved? This is a classical finding. If you are able to find an RAPD in a normal case, it actually indicates the patient is requiring a neurological intervention which requires immediate neurologist to see. Okay, so that's going to be even more important. Then go with the cover test, look for the cover uncover test and the alternate cover test to look for the strabismus, if it is being present or not, what kind of a strabismus, quantify the strabismus based on your either if the visual acuity is good with the Krimsky's test you can do, but if the visual acuity is good, you're going to use a prism bar cover test to quantify it. The visual acuity of one eye is going to be reduced, and then you're going to use a Krimsky or a modified Krimsky and then quantify that. So all these things are going to be very mandatory, and a certain amount of convergence as well as the accommodation also needs to be documented. If in case that is going to get reduced or not, we can have a look. Okay, so in nystagmus, sometimes the amplitude of accommodation is going to be very much difficult to make the patient understand, because the moment you occlude one eye, it is going to, the nystagmus is going to be very high. So sometimes you can see where the patient actually stops reading. So that distance can be measured and that can be quantified for the amplitude of accommodation and then go upon it. Or a pull away method can be used as we do for the special children, and then go upon the quantification of that and look for the pursuits and the saccades movements. So till here is the full evaluation for nystagmus also, and then go upon the treatment wherever is necessary.
Thank you so much, ma'am. It was an elaborative explanation about how to go with the evaluation of nystagmus. And as you said, we also know nystagmus can be purely ocular based or it can be systemic associated. So in that case, how will the therapy differ, ma'am? And if it is congenital, how do we start with the therapy? How will we proceed? How many sittings they do require? What is the outcome of therapies, ma'am?
Basically, outcome of the therapies, we cannot comment what is the outcome of the therapy because it depends on the individual to individual, right? So congenital nystagmus, most of the time they go for a simple glass alone, but when we show the pursuits and the saccade movement changes, and when the academic performance is going to improve, then we can ask them to basic simple exercises at home and then come back. So that way we can see the feedback of the parents as well and then go upon it. Okay, and every year evaluation of the nystagmus patient is also going to be very much mandatory in all these cases. Then if it is going to be neuro intervention or neuro-optometric rehabilitation intervention, it is required. For example, post-trauma or for post-stroke patient or any trauma-involved conditions, then you have to go with a complete orthoptic evaluation as well as look for what kind of a problem they have. Is it visual neglect syndrome that is being there? For example, the patient, if you ask them to draw a clock, they will be able to draw only one side of the clock, like 12 to, from 12 you start and ask them to complete it, only 1 to 12 to 6 only they would have completed. So those are visual neglect type of a condition, which the patient, they themselves will not be aware. If you ask them whether to eat, you can see the patient eating only one side. They would have neglected on the other side because they are not able to perceive it. So these are visual perceptual disorders that can happen. The visual space problems that can be there, where we require yoke prisms or the frontal prisms or pelly prisms to make them understand that in the right side also it's being present, and make them see. These are neuronal inhibitions which we actually see. So we have to identify that and go upon with the treatment like that for those patients. So we have to see how well are they able to improve as such. Okay, so these are the various things which you have to go one by one slowly.
Thank you so much, ma'am. Your explanations and the inputs that we receive from you is so valuable. And Anshi, ma'am, do you have any questions for a moderator today, ma'am?
No, I don't think so. It was a very, very elaborate session. So starting from Divya Bharathi to giving us an overview about the entire theory of nystagmus to Deepa ma'am to taking us to the practical aspects of how can we manage and what are the treatment modalities. I think it was a really wonderful session to have such a bombardment of knowledge. So thank you so much, Deepa ma'am, for giving us so many inputs. And I think the students will really be happy with today's session because they've learned a lot. So thank you once again, Deepa ma'am, for giving us so much of knowledge on nystagmus.
Okay, so I have a sincere request to the students to go back, look what is neuronal inhibitions and what are these neuroplasticity. These neuroplasticity are nowadays bringing up a remarkable changes in patients with post-trauma, post-stroke patients, even in nystagmus patients. Okay, there are syntonic therapy that are being given. I forgot to tell about that. The various tints and the filters actually reduce down the photosensitivity symptoms of the patient, and they help in the balance and the vestibular activities to be improved. So these are the various therapies also that can be given apart from the lenses and the yoke prisms as vision office therapy, in-office therapy, or you can prescribe those things. So what are the spatial relocalization that are being done because of these yoke prisms and all? You can have a look. And filters are also coming up with very good treatment methods as such. Okay, so there are colorful filters coming in flippers and all. With flippers, we can actually have a look. So all these six, you can go look back what is neuroplasticity. And thank you so much, Anshika and Dr. Agarwal College for giving me the opportunity to moderate this session today. Even I had lots of enriched the knowledge from you people, and thank you so much.
Thank you. I would also like to add that ma'am is also the Vice President of OATN. So being the VP of OATN and giving us so much of time. So thank you so much. It's like, the information keeps on coming, ma'am. Whatever she is remembering, she's like, no, this I forgot. So thank you so much for giving us all the insights, ma'am.
Okay, this reminds me, there's an opt-in conference. This is coming at Sri Ramchandra Institute of Higher Education and Research. So please do enroll yourself. The students, 20 students, one faculty can be waived, and there's a 10% discount for the opt-in conference for the students. So 1,800 for per student is coming, and we would like to have a maximum, participation from your college as such. There are cultural activities that are being involved. Various stalwarts in the optometry profession are going to talk. There are workshops that are coming out. Binocular vision workshops by Dr. Rizwana, low vision workshop by Dr. Gopinath, and dispensing by Mr. Satish. Contact lens by Boston Sites Clearals who are coming up with workshops and all. And we are Binox Vision Therapy is coming in for us for the workshops. So these are the various information which I want to actually share. And if possible, you can actually spread these so that you all get benefited with this conference, and all are welcome.
Thank you. Yes, ma'am, we are coming. We are having a few students who are also submitting. So definitely you'll have a team from Dr. Agarwal's coming at opt-in.
Okay.
Yes, ma'am. So over to you, Gomati.
Yes, thank you so much, Anshi ma'am. Thank you, Meenakshi. Divya Bharathi, it was a wonderful presentation. And Deepa ma'am, what a knowledge, ma'am. Thank you so much for joining with us today, ma'am. We're so glad that you're here for Nystagmus celebration.
Thank you so much. It was a last minute preparation by everybody of us. Next time we'll give with a bigger one. Thank you. Thanks.
Sure, ma'am. We would like to host you on another wonderful platform as well, ma'am.
Yeah, sure.
Sure. And best wishes for opt-in, ma'am. So we're also, as Anshi ma'am was telling, we're also working for it, and best wishes for opt-in. Thank you so much, ma'am.
Thank you. Thank you. Thanks a lot.
Dear audiences, thank you all so much for your continuous support towards Optometry series. If you have any questions regarding today's session, please post your questions in the comment box. We'll get back to you with the answers. If you have like this video, please share it with your friends and give a thumbs up. The news for today is admissions are open at Dr. Agarwal's Institute of Optometry for bachelor's, master's, fellowship and internship program. Meet you all in the next episode. Thank you. Bye-bye, everyone. Thank you, ma'am.